Professor Liaw, I would like to thank for sharing the very difficult cases and your protocol to successfully finish the case. Um, I actually have the question similar to Dr. Trang, that when you did significant retraction of the incisors, whether you have any periodontal tissue. But my question is that, do you have any problem with bone fenestration? Because I saw in some cephalometric superimposition that look like you have a lot of retraction, that part of the roots probably is maybe the
Out of the
um,
available.
it's out of the error process, or
Okay,
out of the symphysis. So I
I see.
wonder if you have any problem with that.
Okay. Thank you for the question. Yes, many doctors worry about the situation. And actually, when I look at the cephalogram, it looks like the root is out of the alveolar process. But then I take the CBCT to see if there is a continuous lingual plate or palatal plate with integrity. I check the integrity of the palatal plate, but it seems okay. That is because when we move the roots, okay, there is a thin layer of bone covering the roots. However, the interradicular area, that will not be moved that lingually. So from cephalogram, because that is two-dimensional, so we look like the root is out of the alveolar process. But if we look at the three-dimensional image, especially from the coronal section, we can see the lingual plate is intact. And there is a study. A Korean doctor, they report long-term follow-up records of a case which looked like a fenestration after debonding. However, they can see the intact lingual plate after 10 years follow-up. But in that case, I will say, actually, at the time of debonding, the bone was there. The periosteum is intact, so that they can get this evidence of the intact palatal plate. And this is my idea. And because I check many of my cases, because I have many cases looking like what you mentioned. But when I check the CBCT, it looks pretty safe. It looked pretty safe. And actually, my recent paper about actually, I report two case report, something like that, and I show the CBCT data, and so I myself feel it's good, but patients do not have any periodontal complaints about the gingival recession or bony fenestration. So I think it should be fine. And yeah, I should collect more data and to show the doctors who were worried about this question.
I see. So the bone that you see in the CBCT doesn't show in the cephalometrics, basically, right?
Yes.
Another one, I really like the auto transplant cases of yours, because I have done several of auto transplantation, but not in the fully formed roots. But your cases, you done it in adults with fully formed roots, and this is very interesting. So my questions would be, if you have the failure of these cases, would it be the bone resorption or would it be ankylosis? And how often would you follow up to make sure that they are successful?
Okay. Thank you for the question about auto transplantation. And I think actually the definition of success of auto transplant is all the same. The first one is periodontal attachment. If you got the loss of attachment, you got the loosen of the transplant, of course, it is a failure. But another form of failure is ankylosis. And you will find that you cannot level the auto transplant because you cannot move it with orthodontic force. And so I think for the long term, usually when I do try to submit that case report in HLDO, they ask me to have a follow-up at least 5 years to check if it is still okay. But I submit the case report when I do the 10 years follow-up, so it still look fine. And so I think for adult patient with the fully developed tooth, you know, I feel the one of the number one, they all need root canal treatment. They all need root canal treatment. And if possible, I would suggest to complete the root canal treatment before the transplantation, because you do not want to do the root canal treatment in a little bit mobile auto transplant, because you cannot wait too long before you start the root canal treatment. And the number two, if there is a pre-existing socket for the auto transplant, pre-existing socket, that would be much more predictable because the PDL comes from donor and the recipient.
Right.
So the double sources of the PDL cells make the success rate much higher. However, actually many of my cases, they do not have pre-existing socket when I try to do the auto transplantation. So that's why the success rate for the auto transplantation in cases without pre-existing socket only 60%. But I noticed that if I use premolar, it's much more easier because it's single rooted. It's single rooted. And when I try to try into the recipient socket, it's much more easier because it's not very definitive position you need to achieve because it's conical shape. No matter what, you can insert them to some degrees. And if the occlusion cannot adapt, you may cut the coronal. And if it is still if there is still some problem, you can even cut the apical part because you have already have the root canal fillings. And you can cut the periapical apex, and you can even do the retrograde fillings. And so that's why I like to point out single root, the success rate is pretty high, much higher than molars. And I noticed a requirement mentioned by Dr. Tsukiboshi in his paper is about the flap adaptation. If you can have a very good, very tight flap adaptation, then the success rate would be higher. So, but I also noticed another paper from Tokyo Medical Dental University. They suggest to use the soft LH arch wire for the stability, initial stability. And I will say initial stability is actually very helpful, because if you try to use the suture to get the initial stability, maybe it needs the technique, but use the bracket and arch wire, it seems much more easier, at least from the point of view of orthodontist. We feel that that is quite simple procedure. And of course, if there is still some occlusal trauma we cannot relieve, we can add some bite razor to avoid occlusal trauma. And in the end, use the periodontal pack, I mean co-pack, to protect the wound. I think that is what I can think of.
Thank you very much for the clinical tips. You know, one request, if you could kind of have a webinar from your surgeon, because look like your surgeons must have very good hands. If we have a webinar from your surgeons to our surgeons, so we can produce the same successful results. So that's my request. I would like to congratulate on your presentation. Excellent cases. Thank you very much.
Thank you so much.
Thank you very much to all the panelists. And the next one, we would go for the Q&A. Dr. Junior, please.
Yeah, so we'll go to our Q&A right now, but due to the time restraint, so I think we'll only